The information provided in this video is for educational and informational purposes only, and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have seen in this presentation. Reliance on any information provided in this video is solely at your own risk. It's 2 in the morning. The fluorescent lights of the emergency room hum with a relentless sterile buzz. Through the automatic doors, a scene of pure chaos unfolds. A young man, no older than 19, is flanked by 2 police officers. His eyes are wide, darting, seeing things that aren't there. He's yelling, not in anger but in sheer terror. His parents are a few steps behind. Their faces a portrait of helplessness and heartbreak. The ER is already a war zone. A car crash victim in Bay 1. A possible heart attack in Bay 3. A child with a dangerously high fever. The doctors and nurses are stretched thin, moving with a controlled urgency that barely masks the strain. In this maelstrom of physical trauma, who steps into the storm of a shattered mind? It's not a surgeon with a scalpel, or a cardiologist with a defibrillator. It's a woman who moves with an impossible calm. She doesn't rush. She doesn't raise her voice. She makes eye contact with the young man, not as a threat but as an anchor. She speaks to him in a low, steady tone, acknowledging his fear without validating his delusions. In minutes, the tension in his shoulders begins to drop. The frantic yelling subsides to panicked muttering. She's not just calming a patient. She is de-escalating a crisis that could have easily turned violent, protecting him, the staff, and everyone else in that crowded room. This woman is a psychiatric nurse, and she is one of the most misunderstood, undervalued, and absolutely essential figures in the entire American healthcare system. If you're watching this, chances are you have a picture in your head of what a psychiatric nurse does. Maybe you envision a Nurse Ratched-type figure from the movies, cold and controlling, jangling a set of keys. Or maybe you think of someone who just hands out medication and sits behind a glass partition. The reality is so much more complex, so much more demanding, and infinitely more vital. We are in the middle of a national mental health crisis. 1 in 5 American adults, that's over 57 million people, experiences mental illness in a given year. Suicide is a leading cause of death. Overdoses fueled by despair are devastating our communities. And on the front lines of this invisible war, you will find the psychiatric nurse. So what is their vital role? That's the question we are going to answer. This isn't just for people thinking about a career in nursing. This is for every American who has a friend, a family member, a coworker, or even a child who is struggling. This is for anyone who wants to pull back the curtain on a part of our healthcare system that we rarely see, but that impacts us all. Over the next 10 parts, we are going to take you on a journey deep inside the world of psychiatric nursing. We're going to show you what it really takes to walk onto a locked psychiatric unit, day after day, and face the raw, unfiltered reality of the human condition. You will learn that a psychiatric nurse is a detective, piecing together clues from a patient's disjointed thoughts, family history, and blood work to help form a diagnosis. They are a diplomat, navigating the delicate and often explosive dynamics between a patient and their family, trying to build a bridge of understanding over a chasm of pain. They are a pharmacologist with a deep knowledge of psychotropic medications, understanding how a subtle change in dosage can mean the difference between stability and a full-blown relapse. They are a warrior, often the first and last line of defense when a patient loses control, trained in verbal de-escalation and physical techniques that protect everyone from harm without sacrificing the patient's dignity. More than anything, they are a beacon of hope. For so many patients who feel lost in the darkness of their own minds, who have been abandoned by friends, misunderstood by family, and stigmatized by society, the psychiatric nurse is the one person who consistently shows up, who listens without judgment, and who believes in their capacity to heal. Their battlefield isn't just the hospital. You'll find them in outpatient clinics, helping people manage chronic conditions like schizophrenia or bipolar disorder, so they can live full, productive lives in their communities. You'll find them in schools, intervening with adolescents struggling with anxiety, depression, and eating disorders, catching problems before they spiral out of control. You'll find them in our prisons and jails, where a staggering number of inmates suffer from severe mental illness, often without any other access to care. You'll find them in veterans' hospitals, helping our bravest men and women fight the invisible wounds of war, the PTSD, the trauma, the moral injury that follows them home from combat. They are everywhere, yet they remain largely invisible. The job is not just about compassion, it's about incredible resilience. Imagine spending 8, 10, 12 hours a day absorbing the trauma, the paranoia, the grief, and the despair of your patients. Imagine being verbally assaulted, threatened, or even physically attacked, and having to return the next day with the same level of empathy and professionalism. The emotional toll is immense. The rate of burnout is terrifyingly high. These nurses carry the weight of their patients' suffering long after their shift ends. They are the silent witnesses to the deepest forms of human pain. And they do this within a healthcare system that is profoundly broken. They fight for beds for patients in crisis, only to be told there are none. They battle with insurance companies to get approval for life-saving medications. They discharge patients they know are not ready, simply because the system demands it, sending them back to the very environments that contributed to their illness in the first place. They are forced to be miracle workers in a system that often sets them and their patients up for failure. So why do they do it? What drives a person to choose one of the most emotionally grueling, physically dangerous, and systemically frustrating jobs in medicine? That is the heart of what we will explore. We'll talk to veteran nurses who have seen it all. We'll hear from new graduates full of passion and idealism as they face their first true crisis. We will dissect the science they use, the therapeutic techniques they master, and the incredible intuition they develop. We will look at the history of the profession, from the asylum era to the modern age of neurobiology, and we will look to the future, as new treatments and technologies offer glimmers of hope. This is more than just a job description. This is the story of the people who run toward the fire when everyone else is running away. It's the story of the human connection at its most raw and powerful. By the end of this series, you won't just understand what a psychiatric nurse does. You will understand the immense courage it takes to do it. You will see the profound impact they have not just on their patients, but on the very fabric of our society. And you will never look at the American healthcare system, or the quiet heroes holding it together, in the same way again. To understand their world, you have to step inside it. Not just for a moment, but for a full 12-hour shift. The air itself feels different. It's a space filled with a unique tension, a mixture of profound vulnerability and unpredictable energy. It's 4 in the morning. The fluorescent lights of the inpatient psychiatric unit hum a low, artificial song, a stark contrast to the quiet darkness outside. In most of the hospital, this is a time of relative peace. But here, peace is a fragile, fleeting thing. A sudden crash echoes from down the hall. Not a gentle bump, but the splintering sound of something solid hitting a wall with force. This is the moment where the line is drawn. It's the moment that separates a job from a calling. For the psychiatric nurse on duty, this isn't just a noise. It's a signal. It's a human being in a state of crisis, their internal storm now manifesting in the external world. And this is where we have to confront the biggest, most damaging lie ever told about this profession. When you hear the words psychiatric nurse, what image comes to mind? For millions of Americans, thanks to decades of Hollywood portrayals, it's a cold, unfeeling warden, a tyrant in white, wielding sedatives and restraints like weapons. It's the ghost of Nurse Ratched from One Flew Over the Cuckoo's Nest, a caricature of cruelty that has haunted this field for half a century. Let me be absolutely clear. That image is not just wrong. It is the polar opposite of the truth. It is a slander against a group of professionals whose primary tools are empathy, compassion, and a level of patience that would humble a saint. The real psychiatric nurse doesn't run toward that crash with a syringe and a scowl. They walk. Deliberately. Calmly. Their heart rate might be climbing, their adrenaline might be pumping, but on the outside, they are an island of tranquility in a sea of chaos. They enter the room and they don't see a monster. They don't see a problem to be subdued. They see a person who is terrified, a person whose brain is lying to them, telling them they're in danger, that they're worthless, that the world is ending. The patient, let's call him John, is a young man, a college student, who was brought in 2 days ago in the grips of his first psychotic break. The brilliant mind that was acing calculus exams is now trapped in a labyrinth of paranoia and auditory hallucinations. The chair he threw wasn't an act of aggression, it was an act of desperation. He was trying to fight off the voices only he could hear. The nurse, let's call her Maria, doesn't yell. She doesn't command. Her first words are quiet, simple, and direct. John, it's Maria. I'm here. You are safe. She doesn't enter his personal space. She maintains a safe distance, her posture open, her hands visible. This is a skill. It's a therapeutic technique called de-escalation, and it is an art form. She is reading his body language, the tension in his shoulders, the darting of his eyes. She is assessing his mental state in real time, not from a textbook, but from the raw, unfiltered data of human distress, right in front of her. She uses her voice like a surgical instrument. She validates his fear without validating the delusion. She'll say, "I can see that you're incredibly frightened right now," instead of, "There's nothing to be afraid of." One statement builds a bridge, the other builds a wall. For the next 20 minutes, Maria talks with John. She listens. She asks about the voices. She offers him a choice, a small piece of control in a world where he has none. "Would you be willing to walk with me to the quiet room for a little while? Or we can sit here. It's up to you." This is the reality. It's not about control. It's about connection. It's not about power. It's about empowerment. A psychiatric mental health nurse, or PMHN, is a detective, a therapist, a pharmacist, a teacher, and a guardian, all rolled into one. They are trained to see the subtle signs of a mood shift, to understand the complex interplay of brain chemistry and life experience, to know when a patient's agitation is a symptom of their illness, a side effect of their medication, or a perfectly rational response to the trauma they've endured. Their scope of practice is immense. In the morning, Maria might be leading a group therapy session on coping skills for anxiety. By midday, she's collaborating with a psychiatrist to adjust a complex medication regimen for a patient with bipolar disorder, carefully monitoring for side effects and therapeutic response. In the afternoon, she's on the phone with the patient's family, educating them about the illness, explaining the treatment plan, and providing them with the support they desperately need. They are the central hub of the mental health care team, the professionals who spend the most time with the patients, building the therapeutic rapport that is the absolute bedrock of recovery. And they don't just work in hospitals. That's another misconception. You will find these quiet heroes everywhere. They are in our schools, helping children navigate ADHD and depression. They are in our veterans' clinics, working with soldiers who carry the invisible wounds of war. They are in our community health centers, providing care to the homeless and the underserved. They are on telehealth calls, reaching people in rural America who would otherwise have no access to mental health care. They are in our prisons, caring for an inmate population where severe mental illness is tragically rampant. They are on the front lines, in every corner of society where mental health and human struggle intersect. Becoming a psychiatric nurse requires a unique blend of scientific rigor and profound humanity. It is a profession that demands you be both a scientist and an artist. The science is the neurobiology, the psychopharmacology, the deep understanding of the diagnostic manuals and treatment algorithms. It's knowing the difference between serotonin and dopamine, understanding how a specific medication works on a specific neural pathway, and recognizing the symptoms of schizophrenia versus schizoaffective disorder. This is the bedrock of knowledge that ensures patient safety and effective treatment. But the art is something else entirely. The art is sitting with someone in their darkest hour and not flinching. It's absorbing their pain, their anger, their despair, and reflecting back hope. It's building trust with someone who has been taught by their illness that no one can be trusted. It's finding the right words, the right tone, the right gesture to break through the wall of psychosis or the fog of depression. The art is seeing the person behind the diagnosis, the individual behind the illness. It's knowing when to push, when to pull back, and when to just be silent and present. No textbook can teach you how to look into the eyes of a mother suffering from postpartum psychosis and reassure her that she is not a monster. No lecture can prepare you for the feeling of holding the hand of an elderly man with dementia as he weeps for a wife he can no longer remember. And no simulation can replicate the quiet triumph of seeing a patient who weeks ago was catatonic and nonverbal smile and say thank you for the first time. This combination of hard science and intuitive art is what makes the role so vital and so incredibly demanding. These nurses operate at the nexus of the mind, the brain, and the spirit. They are stewards of the most complex, most fragile, and most fundamental part of our being, our mental health. They are the steady hand in the storm, the calm voice in the chaos. But what happens when that calm voice and therapeutic presence aren't enough? What happens when the storm inside a patient's mind is a literal biological hurricane, a chemical war being waged against the self? That is when the psychiatric nurse must rely on the other half of their expertise, moving from the art of connection to the hard science of intervention. And that is where their role becomes even more critical and even more misunderstood. This transition from connection to intervention is one of the most jarring and misunderstood aspects of psychiatric nursing. To the outside world, it can look like a switch has been flipped. One moment, the nurse is a compassionate listener. The next, they are an agent of clinical authority. But from the inside, it's not a switch at all. It's a continuum. It's the application of a different tool for the same fundamental purpose: to restore a person's ability to live their life. Imagine a patient, we'll call him David. David is 22 years old, a brilliant college student who suddenly started believing that his professors were part of a vast conspiracy to steal his thoughts. He hasn't slept in 4 days. He's barricaded himself in his room, and his parents, terrified, have finally managed to get him to an emergency department. He is agitated, paranoid, and speaking in a word salad, a jumble of disconnected phrases that make no logical sense. Here, the art of connection is the first step, but it hits a wall. You can't build a therapeutic rapport with someone who believes you're a secret agent sent to harm them. You can't reason someone out of a delusion that has completely hijacked their perception of reality. David's brain is, in a very real biological sense, on fire. The neural pathways that govern logic, perception, and emotional regulation are misfiring chaotically. This is not a failure of character. This is not a lack of willpower. This is a medical crisis, as acute and as life-threatening as a heart attack or a diabetic coma. And this is where the psychiatric nurse's scientific training kicks into high gear. The first step is a rapid, yet incredibly detailed assessment. This isn't just a friendly chat. It's a forensic investigation of the mind. The nurse is conducting what's called a mental status exam, or MSE. They are observing David's appearance. Is he disheveled? Are his pupils dilated? They're noting his behavior. Is he pacing? Is he responding to internal stimuli like hearing voices? They're analyzing his speech. Is it pressured? Is it loud? Is it nonsensical? They're assessing his mood and affect. Does he report feeling terrified, but is he laughing inappropriately? They're probing for the content of his thoughts. What are the specific delusions? Are there thoughts of harming himself or others? Every single observation is a data point. Every mumbled phrase is a clue. The nurse is piecing together a puzzle to understand the nature of David's psychosis. Is this schizophrenia? Is it a drug-induced psychosis? Is it the first presentation of bipolar mania? Could there be an underlying medical cause like a brain tumor or an infection that's causing these psychiatric symptoms? The nurse works with the medical team to rule out these organic causes, drawing blood, checking vital signs, and gathering a history from the terrified parents. This is not guesswork. This is differential diagnosis, a systematic process of elimination grounded in pathophysiology, neurology, and pharmacology. Based on this comprehensive assessment, a plan is formed. And in a state of acute psychosis like David's, that plan almost always involves medication. Now, this is the part that makes people uncomfortable. It's the part that fuels the stereotypes of psychiatric care as something coercive, something that zaps people of their personality. But let's reframe this. If David were in a diabetic coma, no one would question the use of insulin. It's understood as a life-saving intervention to correct a dangerous biological imbalance. For David, his brain is in a state of profound neurochemical imbalance. There is an excess of the neurotransmitter dopamine in certain pathways of his brain, which is strongly linked to the hallucinations and delusions of psychosis. The nurse's role here is critical. They are often the one who must explain the need for an antipsychotic medication to David and his family. They have to cut through the fear and stigma and explain it for what it is: a fire extinguisher for the fire in his brain. It's not a personality eraser. It's not a chemical straitjacket. It's a tool designed to lower the volume on the terrifying internal chaos, to restore the brain's ability to think clearly, so that the person, the real David, can re-emerge. The administration of that medication is a profound responsibility. The nurse must know the exact mechanism of action. They need to know that this specific medication works by blocking dopamine D2 receptors. They must know the potential side effects, from short-term sedation and muscle stiffness to long-term risks like metabolic syndrome or movement disorders. They are the frontline for monitoring. Is the medication working? Is David's heart rate stable? Is he developing a tremor? Is he having a rare but life-threatening allergic reaction? They are constantly assessing, documenting, and titrating the treatment in collaboration with the physician or nurse practitioner. This is the hard science. It's memorizing hundreds of medications, their interactions, and their side effect profiles. It's understanding pharmacokinetics, how a drug is absorbed, distributed, metabolized, and excreted by the body. It's knowing that a patient's genetics, their diet, even whether they smoke, can dramatically change how a medication works. But the science doesn't stop at pharmacology. Let's say David, fueled by his paranoia, refuses the medication and becomes physically aggressive. The nurse must then lead a de-escalation. This too is a science. It's the science of applied neurobiology. The nurse knows that David is in a state of amygdala hijack. His brain's threat detection center is firing on all cylinders, and his prefrontal cortex, the part responsible for rational thought, is offline. Shouting at him would be like throwing gasoline on the fire. Arguing with his delusion would only validate his fear that he's being tricked. Instead, the nurse uses specific, evidence-based verbal de-escalation techniques. They keep a safe distance. They use a calm, low tone of voice. They stand at an angle, not head-on, which is perceived as less confrontational. They use short, simple sentences. They don't argue, they reflect. It sounds like you feel really scared right now. It sounds like you feel like you can't trust anyone. This isn't just being nice. This is a clinical intervention designed to engage the parasympathetic nervous system, the body's rest and digest system, to counteract the fight or flight response. The nurse is using their words and their presence as a neurological tool to bring David's prefrontal cortex back online. In many cases, this is enough. The patient calms, feels heard, and may even agree to take the medication voluntarily. But sometimes it's not. Sometimes a patient is in imminent danger to themselves or to others. And in those rare, last resort situations, the nurse must lead the team in a therapeutic hold and administer medication via injection. This is the single most misunderstood and misrepresented action in all of mental health care. It is never ever done lightly. It is a failure of all other options. It is a medical intervention to prevent a greater harm, to prevent a patient from blinding themselves, from attacking a staff member, from suffering a complete and catastrophic psychotic break. The science here is precise. The knowledge of anatomy to give the injection safely. The knowledge of pharmacology to give the right fast-acting dose. The constant monitoring of vital signs to ensure the patient's physical safety throughout. After an event like this, once the medication takes effect and the patient is calm and resting, the nurse's job is far from over. The scientific process continues. They document every single detail of the event, not to cover themselves, but to create a data trail. What were the triggers? What de-escalation techniques were attempted? How did the patient respond? This information is vital for adjusting the treatment plan, for learning what works and what doesn't for this specific individual. The hard science of psychiatric nursing isn't cold or impersonal. It's the very scaffold upon which healing is built. It's the act of clearing the storm so that the person can find their way back to shore. For David, after a few days on medication, the storm begins to subside. The voices fade. The paranoid thoughts, while still present, lose their terrifying conviction. He sleeps. He eats. And for the first time in weeks, he is able to have a coherent conversation. The fire is out. The biological crisis has been stabilized. But the work is just beginning. Because now that the science has created a foundation of stability, the art must return, more powerfully than ever. The nurse who scientifically assessed his psychosis and administered the precise medication must now become the trusted human who sits with him, helps him make sense of what just happened, and begins the slow, painstaking process of helping him rebuild his sense of self. And that alliance, forged in the aftermath of crisis, is one of the most powerful forces in all of healthcare. But what is that alliance, really? It's not just being friendly. It's not just being a good listener. It's a clinical tool, as precise and as vital as a surgeon's scalpel. It's a concept we call therapeutic communication, and it is the absolute bedrock of psychiatric nursing. It is a science and an art form, a delicate dance of words and silence, of questions and reflections, that allows a nurse to enter the terrifying, chaotic world of a person in psychosis and build a bridge back to reality. Imagine a young woman, let's call her Sarah, admitted for the first time with severe paranoia. She believes her food is poison, that the staff are government agents, and that the television is broadcasting her thoughts. Her reality has fractured. Every friendly face is a mask, every kind word a trick. If a nurse walks in with a big fake smile and says, "Hi Sarah, how are we doing today? Time for your meds," she will be met with a wall of terror and hostility. The alliance is dead on arrival. Sarah will refuse the medication, a struggle might ensue, and her paranoia will be validated. In her mind, the agents are now trying to force her to take the poison. The cycle of trauma continues. Now watch a skilled psychiatric nurse enter that same room. She doesn't rush. She stands by the door for a moment, assessing the environment. She's not smiling broadly. Her expression is calm, neutral, and open. She doesn't use a cheerful, booming voice. She speaks softly, clearly. "Sarah, my name is Jessica. I'm a nurse here. I'm going to be sitting in this chair for a little while. I'm not going to do anything. I just want to be here in the room with you for a bit." She doesn't approach the bed. She gives Sarah space. She sits quietly, patiently. She is a non-threatening presence. After 5 minutes of silence, Sarah might whisper, "You're one of them." The untrained person's instinct is to deny. "No, I'm not. I'm here to help you." But Jessica knows that will only escalate the situation. Instead, she uses a technique called validation. She doesn't validate the delusion. She validates the feeling behind it. She says, "It must be incredibly frightening to feel like you're surrounded by people you can't trust." Think about the power of that statement. She hasn't agreed that she's an agent. She hasn't argued. She has stepped into Sarah's emotional reality and acknowledged her fear. For the first time in days, maybe weeks, Sarah feels heard. Not agreed with, but heard. Her terror has been seen and acknowledged. A tiny crack appears in the wall of her paranoia. She might say, "They're trying to poison me." Jessica won't say, "No one is poisoning you, that's your illness talking." Instead, she might reflect, "You're worried the food isn't safe to eat." Again, she's not arguing with the reality of the delusion. She's focusing on the tangible worry. This is a subtle but profound difference. She is building trust, brick by painstaking brick, not by trying to tear down Sarah's delusional fortress, but by offering a safe space just outside its walls. This is the art. It's knowing when to speak and when to be silent. It's using open-ended questions like, "What has this experience been like for you?" instead of closed-ended ones like, "Are you hearing voices?" It's paraphrasing what a patient says. "So what I'm hearing is you feel like you've lost all control." To show you're not just listening but you're understanding. This is a skill that is learned and practiced over years. Nurses are trained to recognize their own biases, their own emotional triggers. If a patient is screaming insults, the nurse has to have the self-awareness to not react defensively, to understand that the anger is a symptom of the illness, a manifestation of terror or pain, not a personal attack. They become a container for that rage. They absorb it, hold it, and offer back calm and safety. It is an act of incredible emotional discipline. And this isn't just about psychosis. Think of the patient with severe depression who can barely speak, who feels like a worthless burden on the world. A nurse might not use many words at all. They might simply say, "I'm going to sit with you for 10 minutes. And they do. They sit in the heavy silence, bearing witness to the person's pain without trying to fix it or cheer them up. That silent presence can communicate more acceptance and worth than 1,000 empty platitudes. It says, "Your pain is not too much for me. You are not a burden. I can be here with you in this darkness." Or consider the patient with borderline personality disorder, who experiences emotions with searing intensity and often has a deep-seated fear of abandonment. For them, a nurse's consistency is everything. When the nurse says, "I will be back in an hour to check on you," and then returns in exactly 1 hour, that single act builds more trust than any promise. It demonstrates reliability. It creates a small island of predictability in a chaotic internal sea. Every kept promise, no matter how small, is a therapeutic intervention. This is why we say that the most important tool in psychiatric nursing is the nurse themselves. Their personality, their patience, their self-awareness, their ability to regulate their own emotions in the face of chaos. This is the therapeutic use of self. They are the medicine long before any pill is offered. Because what all these techniques are doing piece by piece is answering the patient's unspoken question. Are you safe? Can I trust you? Do you see me as a person or just a diagnosis? By consistently demonstrating safety, reliability, and unconditional positive regard, the nurse slowly, carefully, constructs that therapeutic alliance. It is this alliance that allows a patient to feel safe enough to be vulnerable, to confide their fears, to question their own delusions, and to finally accept help. It's what makes a patient who is terrified of being poisoned willing to take a small pill from the hand of a nurse they have come to trust. But words and presence and trust, they aren't always enough. They are the essential foundation, the runway from which healing takes flight. But sometimes the storm inside the mind is a biological hurricane, a chemical imbalance so profound that no amount of talk can calm the waves. The brain's own wiring is short-circuiting, and the person is trapped in a feedback loop of terror or despair. And that's when the psychiatric nurse must become a master of a different language entirely. The complex, powerful, and often misunderstood language of psychopharmacology. It sounds daunting, clinical, but for the psychiatric nurse, it's less like reading a textbook and more like being a master sound engineer in a state-of-the-art recording studio. The patient's brain is the mixing board, a vast console with millions of sliders, knobs, and switches. Some are pushed way too high, creating a deafening feedback of anxiety. Others are pulled way too low, resulting in a flat, muted silence of depression. And some are creating chaotic, distorted signals, a frightening static of psychosis. The psychiatrist might write the initial musical score, identifying which sections need adjustment. But it's the nurse, with their hands on the console day in and day out, who fine-tunes the mix. They are the ones listening, observing, and making the subtle adjustments that can turn cacophony into clarity. This isn't about giving pills. That's a dangerous oversimplification. This is about strategic, targeted intervention at the synaptic level. The psychiatric nurse is the frontline operator in this incredibly delicate process. While a psychiatrist or a psychiatric nurse practitioner often makes the initial prescription, the bedside nurse is the one who sees the immediate, real-world impact. They are the data collectors, the first responders to side effects, and the primary educators who help a patient understand why they are taking this chemical key and how to use it. They witness the first flicker of light returning to a patient's eyes after weeks of darkness. They see the racing thoughts of mania begin to slow to a manageable pace. And they also see the troubling hand tremor, the sudden weight gain, or the dangerous spike in blood pressure that signals the mix is wrong. They are the guardians of the therapeutic window, that razor-thin space where a medication is effective but not yet toxic. To navigate this, they have to be fluent in the four major families of these powerful tools. First, you have the most well-known, the antidepressants. Think of these not as happy pills, but as a kind of neurochemical fertilizer. For a brain depleted by chronic depression, it's like soil that's been stripped of its nutrients. You can plant the best seeds, therapy, coping skills, social connection, but nothing will grow. Medications like SSRIs or selective serotonin reuptake inhibitors don't just dump happiness into the brain. Instead, they act like a sophisticated irrigation system. They block the reabsorption or reuptake of serotonin, one of the brain's key mood-regulating neurotransmitters. This means the serotonin that's already there gets to linger in the synaptic gap for longer, giving it more time to do its job, to transmit its signal of well-being. The nurse's job is to help the patient through the first few weeks, when side effects can be pronounced, but the therapeutic effects haven't kicked in yet. They have to be the voice of hope, explaining that the soil is being tilled, that it takes time for the nutrients to settle before new growth can begin. Then, you have the antipsychotics, perhaps the most feared and misunderstood class of all. The very name conjures up archaic images of sedation and control. But for a person in the grips of psychosis, these medications can be a lifeline back to reality. Psychosis isn't just seeing or hearing things. It's a fundamental breakdown in the brain's ability to distinguish what's real from what isn't. The mixing board is now creating phantom signals, blasting static through the speakers. Atypical antipsychotics, the more modern class, work primarily on dopamine pathways, acting like a highly sophisticated noise cancellation system. They don't just mute everything. They selectively dampen the erratic, intrusive signals that cause hallucinations and delusions, while allowing the clearer, reality-based signals to come through. But this power comes with significant risk. The nurse is on high alert, monitoring for a constellation of potential side effects. Metabolic syndrome, which can lead to diabetes and heart disease, or extrapyramidal symptoms. Distressing movement disorders like tremors, rigidity, and a terrifying restlessness called akathisia. They are the vigilant watchtower, ensuring that the very tool meant to bring someone back to reality doesn't inadvertently cause profound harm to their physical body. Next are the anxiolytics, particularly the benzodiazepines. If antidepressants are fertilizer and antipsychotics are noise cancellation, then benzos are the emergency brake. When a patient is in the throes of a full-blown panic attack, their sympathetic nervous system is in overdrive. It's a runaway train of terror. Benzodiazepines work by enhancing the effect of GABA, the brain's primary inhibitory neurotransmitter. In our mixing board analogy, GABA is the master calm down and shut up signal. Benzos amplify this signal, rapidly and powerfully slamming the brakes on the central nervous system. The relief can be profound, almost miraculous. But this is a double-edged sword. The very speed and efficacy that make them so useful also make them incredibly addictive. The The brain quickly adapts, needing more and more to achieve the same effect, leading to physical dependence. Here, the psychiatric nurse acts as a judicious gatekeeper. They administer these PRN, or as needed, medications not just on request, but based on a careful assessment. Are there other, non-pharmacological interventions we can try first? Deep breathing, grounding techniques? Is this true? Overwhelming panic? Or is it a learned craving for the medication's relief? The nurse must teach the patient that the emergency brake is for emergencies only, not for everyday driving. Finally, we have the mood stabilizers. For someone with bipolar disorder, life is a seismic oscillation between the frenetic, godlike energy of mania and the crushing subterranean despair of depression. Mood stabilizers, like the legendary lithium, act like seismic dampers installed in the very foundation of the mind. They don't necessarily stop the ground from shaking, but they absorb the violent energy of the mood swings, preventing the entire structure from collapsing. Lithium is a fascinating element, a simple salt that has a profound ability to level out these dangerous peaks and valleys. But it is notoriously difficult to manage. The difference between a therapeutic dose and a toxic dose is terrifyingly small. A little too much and you risk kidney damage, tremors, even death. A little too little, and the seismic forces of the illness return. This is where the nurse's role is paramount. They are responsible for meticulous monitoring of blood levels, for educating the patient on the critical importance of consistent hydration and salt intake, and for recognizing the earliest, most subtle signs of toxicity, a slight tremor, a bit of nausea, confusion. They are the geologists of the mind, constantly checking the seismograph to ensure the building remains standing. But mastering these four families is only the beginning. The real art lies in the day-to-day application. It's a process called titration, starting with a low dose and slowly, carefully increasing it over days or weeks. The nurse is the primary observer in this process. They are a detective looking for clues. It's not just about asking, "How are you feeling?" It's about observing. Is the patient who is pacing relentlessly now able to sit and watch TV for 10 minutes? That's a data point. Is the patient who wouldn't make eye contact now glancing up when you enter the room? Data point. Are they complaining of a dry mouth? Dizziness upon standing? A new strange dream? Every single observation is a piece of the puzzle. The nurse synthesizes this information, the subjective reports from the patient and the objective data they observe, and communicates it to the rest of the treatment team. They are the ones who can say with confidence, "I think we can increase the dose," or "We need to hold. I'm seeing signs that this isn't being tolerated well." This is why the relationship, the therapeutic alliance, is so critical. A patient isn't going to trust you with information about their side effects, their fears about the medication, or its subtle benefits unless they trust you. The nurse demystifies the process. They explain that these aren't personality-erasing pills. They are tools. They are a crutch to be used when your leg is broken, allowing you to begin the physical therapy you need to learn to walk again. The medication doesn't do the walking for you. It simply provides enough stability, enough relief from the overwhelming symptoms, so that the real work can begin. It quiets the deafening noise of psychosis so a person can engage in therapy. It lifts the crushing weight of depression just enough for a person to get out of bed and practice a new coping skill. It tames the fire of mania so a person can begin to rebuild the relationships their illness may have burned. The medication is the chemical key, but the nurse, through their expertise, their observation, and their unwavering human connection, is the one who helps the patient find the courage to turn it, to open the door, and to take that first tentative step back into their own life. And that first step is often the most terrifying. It's a step out of the chaotic, yet strangely familiar, world of acute crisis and into the uncertain landscape of recovery. The storm may have passed, but the wreckage remains. And standing there amidst the debris is the psychiatric nurse, not with a mop and bucket, but with a blueprint for rebuilding. Their first job is to ensure the storm doesn't immediately return. This is the art and science of de-escalation, a skill that is part psychology, part intuition, and part sheer force of will, expressed with absolute calm. Imagine a young man, let's call him Alex, admitted to the unit in the grips of a severe paranoid delusion. To him, the hospital isn't a place of safety. It's the enemy's headquarters. The nurses aren't caregivers. They are agents sent to harm him. Every shadow is a threat, every quiet word a conspiracy. His heart is pounding, his fists are clenched, and he's backed into a corner, shouting, ready to fight for his life against a threat that exists only in his mind. This is a critical moment, a fork in the road. One path leads to restraints, forced medication, and trauma for both Alex and the staff. The other path is paved with the specialized skills of the psychiatric nurse. Another healthcare professional might see a threat. A psych nurse sees terror. They see a human being whose brain is betraying them, drowning them in fear. So the nurse doesn't rush in. They stop. They keep a safe distance, turn their body to the side to appear less confrontational, and keep their hands open and visible. They speak in a low, steady tone, a human anchor in a sea of psychosis. They don't argue with the delusion. Arguing with the delusion is like arguing with a hurricane. You will lose. Instead, they validate the emotion behind it. Alex, I can see you are absolutely terrified right now. This must be incredibly scary for you. I'm not going to hurt you. My name is Sarah, and I'm here to help you feel safe. Notice the language. It's not, there's nothing to be afraid of. It is, I can see you are afraid. It's validation. It's connection. The nurse might then offer a simple binary choice. Would you like to sit here with me for a moment? Or would you prefer we walk to the quiet room where there's less noise? This small act of giving control back to Alex is monumental. In his world of powerlessness, a simple choice is a lifeline. He's no longer just a reactor. He's a participant. Slowly, minute by agonizing minute, the nurse talks him down not by dismissing his reality, but by offering him a safer one to share with her. This isn't just talking someone down. This is a high-stakes psychological negotiation, and the nurse is the world's most unsung diplomat, brokering peace with a mind at war with itself. This one-on-one intervention is just one piece of a much larger puzzle. The psychiatric nurse is also the architect of what's known as the therapeutic milieu. That's a clinical term for the entire social and physical environment of the unit. The nurse understands that healing doesn't just happen in a therapist's office. It happens in the hallway conversations, during the mealtime routines, in the group sessions. Every single interaction is a potential opportunity for growth or a potential trigger for relapse. The nurse is the constant guardian of this fragile ecosystem. They are the ones who ensure the environment is predictable and safe, which is profoundly calming for minds steeped in chaos. They set firm, consistent boundaries, which act as guardrails for patients who have lost their own internal sense of control. They skillfully manage the complex interpersonal dynamics of a dozen or more individuals, all struggling with their own demons, all living in close quarters. Imagine being the referee, counselor, and parent to a room full of people where one person's mania could trigger another's anxiety, and that person's outburst could trigger another's trauma. The nurse navigates this emotional minefield 24 hours a day, fostering a culture of respect and safety where patients can begin to practice the very social skills they'll need to survive and thrive on the outside. It's a constant, delicate balancing act, and the nurse is the fulcrum upon which the entire system rests. And then, there is the crucial role of medication management. This is so much more than just dispensing pills from a cart. In psychiatry, medication is often a process of careful, collaborative discovery. The nurse is the frontline scientist and data analyst in this process. The psychiatrist may prescribe the medication, but it is the nurse who is with the patient day in and day out, observing its effects with a trained eye. They're not just looking for the big, obvious improvements. They're noticing the subtle shifts. Is the patient who was catatonic now making eye contact for a second longer? Is the patient with crippling anxiety now able to sit with the group for 5 minutes instead of 2? Did the new antipsychotic cause a slight tremor in someone's hand that only a trained eye would spot? Did a patient sleep through the night for the first time in a month? This is vital data. The nurse is the primary source of information that guides the entire treatment team in titrating dosages and making medication changes. But beyond observation, there is the art of education and alliance building. Many patients arrive on the unit deeply suspicious of medication. They've been misinformed by the internet, they've had bad experiences in the past, or the very nature of their illness makes them paranoid about being poisoned. A nurse can't just hand them a cup of pills and say, "Take this." They sit down with the patient. They explain what the medication is for in plain language. They talk about the potential benefits and the common side effects. They listen to the patient's fears and validate them. "Yes, I understand why you're worried about weight gain. That's a valid concern. Let's talk about how we can manage that with nutrition and exercise, while we see if this medication can help quiet the voices." This process transforms the act of taking medication from a passive submission to an active partnership. The patient becomes an ally in their own recovery. The nurse empowers them with knowledge, building the trust necessary for them to engage in their treatment. This therapeutic alliance is often the single most important factor in whether a patient will continue their medication after discharge, and therefore, whether they will remain stable in the community. This points to the final and perhaps most critical role the nurse plays on an inpatient unit. They are the architects of the discharge. From the moment a patient is admitted, the nurse is already thinking about the day they will leave. The goal of inpatient psychiatry is not to create a permanent home, it's to be a temporary shipyard, a place to repair the vessel so it can sail on its own again. The nurse is the chief engineer of this process. They are the central communication hub, coordinating with the entire team, the doctors, the therapists, the social workers. But their reach extends far beyond the hospital walls. They are on the phone with family members, educating them about the patient's illness, teaching them how to be a supportive but firm part of the recovery plan. They are coordinating with outpatient clinics to ensure a follow-up appointment is scheduled before the patient even walks out the door. They are working with case managers to address practical barriers like housing, transportation, and insurance. Every piece must be in place. A successful discharge is a warm handoff, not a shove out the door. The nurse ensures that the patient isn't just leaving with a bottle of pills, but with a concrete plan, a support system, and a safety net. They are bridging the gap between the structured, 24/7 support of the hospital and the chaotic reality of the outside world. This meticulous, often thankless work is the single best defense against the tragic revolving door of psychiatric readmissions. It's the nurse who ensures that the first tentative step out the door isn't a step off a cliff, but the first step on a clear, well-lit path toward a sustainable recovery. They don't just put out the fire. They help rebuild the house and hand the patient the tools they need to make it fireproof for the future. And that fireproofing, that rebuilding, doesn't just happen within the four walls of a hospital. Because mental illness doesn't live in a hospital. It lives in a studio apartment in a bustling city. It lives on a farm 3 hours from the nearest doctor. It lives in a suburban home, behind a white picket fence. It lives on the streets under a bridge. The real test of recovery, the true measure of the work, begins the moment that discharge paperwork is signed. This is where the psychiatric nurse's role explodes in complexity, moving from a controlled environment to the chaotic, unpredictable theater of everyday life. This is the world of community psychiatry, and it is a frontier where these nurses are the pioneers, the diplomats, and the sole lifeline for millions. Imagine a small, unassuming clinic tucked into a strip mall. This is a community mental health center, an anchor for people managing chronic conditions like schizophrenia, bipolar disorder, or severe depression. Here, the psychiatric nurse is the constant. They're not just an authority figure in scrubs. They are the familiar face, the consistent presence in a life that might be defined by inconsistency. They are the ones who administer the long-acting injectable medications that can be the difference between stability and a full-blown psychotic break. That monthly or bi-monthly injection isn't just a medical procedure. It's a ritual. It's a check-in. It's a 20-minute window where the nurse can truly assess what's going on. They're not just looking at a chart. They're looking at the person's eyes. Are they clear or clouded? They're listening to their speech. Is it fluid or fragmented? They're noticing their clothes. Are they clean? Do they fit? These are the subtle data points of a person's reality, and the nurse is trained to read them like a vital sign. In that short visit, they might connect the patient with a food bank, help them strategize how to talk to their landlord, or simply listen to a story about their cat. They are the quarterback of a fragmented care system, ensuring that the psychiatrist, the therapist, the case manager, and the patient are all playing from the same book. Without them, the system collapses into a series of disconnected appointments and missed opportunities. But what happens when the patient can't or won't come to the clinic? What about the individual so consumed by paranoia that they've barricaded themselves in their apartment? Or the person whose depression is so profound, they haven't left their bed in weeks? For them, the hospital's revolving door becomes a life sentence. This is where one of the most intense and remarkable forms of psychiatric nursing comes into play. The Assertive Community Treatment Team, or ACT team. This isn't healthcare delivered in an office. This is healthcare on wheels. The psych nurse on an ACT team is part medic, part detective, part crisis negotiator, and part social worker. Their office is a beat-up sedan filled with medical supplies, granola bars, and bottles of water. They don't wait for the patient to seek help. They take the help to the patient, wherever they are. Picture this. A nurse approaching a homeless encampment. They're not there to force treatment. They're there to build the most fragile and essential thing in mental health care: trust. Maybe the first day they just leave a clean pair of socks and walk away. The next day, a bottle of water. The day after that, they might get a single nod of acknowledgement. It could take weeks, even months, of this patient, persistent, non-judgmental presence before a single word is exchanged. They are masters of de-escalation in the wild, using nothing but their voice and their posture to calm a person terrified by unseen demons on a crowded sidewalk. They are the ones who sit on a dirty curb and help a patient sort their medications into a weekly pill organizer, explaining not just what the pills do, but why they matter, connecting it back to the patient's own stated goals. Do you want to see your daughter again? Do you want to get an apartment? This medication is a tool to help you get there. They are celebrating the smallest victories: a shower, a hot meal, a full night's sleep, because they know these aren't small things. They are monumental steps on the long road back. This work extends into the digital realm as well. In the vast rural landscapes of America, the nearest mental health professional can be a 4-hour drive away. Technology has tried to bridge that gap with telepsychiatry, and psychiatric nurses are on the front lines of this digital frontier. They are the ones conducting therapy sessions and medication checks with a farmer in Montana who's struggling with suicidal thoughts, or a new mother in rural Appalachia battling postpartum depression. But this presents a unique and profound challenge. So much of psychiatric assessment is nonverbal. It's the restless leg, the darting eyes, the subtle tremor in the hands. How do you build a therapeutic rapport through a pixelated screen? How do you create a sense of safety and trust when you are a face on a laptop? It requires an entirely new level of listening, an ability to detect the slightest hesitation in a voice or the flicker of fear in an eye, even through a poor internet connection. They are becoming experts in a new kind of human connection, one mediated by technology but grounded in the same fundamental principles of empathy and care. But there is another world, far from the community clinic and the open road, where the stakes are arguably the highest. What happens when a mental health crisis intersects with the criminal justice system? When a person's illness leads not to an ambulance, but to a police car? This is the realm of the forensic psychiatric nurse. They work in jails, prisons, and forensic hospitals, occupying a space of incredible moral and ethical complexity. Their patient is also an inmate. The environment is designed for security and punishment, not healing and therapy. Yet, it is here that these nurses perform some of their most vital work. They might be called to a county jail to assess an inmate who is refusing to eat, trying to determine if it's a hunger strike or a symptom of catatonic depression. They are the ones who have to build a rapport with a man in solitary confinement, speaking to him through a slot in a steel door, trying to convince him to take the antipsychotic medication that could quiet the terrifying voices in his head. They perform competency evaluations, sitting with defendants to determine if they even understand the charges against them, a judgment that can alter the entire course of a person's life. They are navigating a dual role. They are caregivers bound by an oath to heal, but they are also part of a correctional system, bound by rules of security. They must advocate for their patients' health while maintaining professional boundaries in an environment where manipulation can be a survival skill. It is a tightrope walk over a canyon of ethical dilemmas. They are providing care to a population that society has locked away and tried to forget, affirming the humanity of individuals in a system that often strips it away. They are the last line of defense, the final safety net for the most vulnerable, most marginalized people in our entire society. From the quiet consistency of a community clinic, to the mobile intensity of an ACT team, to the sterile interface of a video call, to the cold reality of a prison cell, the psychiatric nurse adapts and engages. They are the flexible, dynamic heart of a system that is often rigid and broken. But this constant adaptation, this relentless exposure to trauma, this profound emotional and psychological labor, it comes at a cost. To bear witness to so much pain, to carry the weight of so many broken lives, to pour so much of yourself into people who may never get better, it takes a toll that is impossible to measure. What kind of person can withstand this? What kind of internal fortitude does it take to walk into these environments, day after day, and not just survive, but provide genuine, compassionate care? What happens when the caregiver, the one who is supposed to be the rock, begins to crack under the pressure? The answer is that they don't shatter all at once. It's not a sudden dramatic explosion. It's a slow, quiet erosion. It's a hairline fracture that spreads under immense, constant pressure until the entire foundation is compromised. It starts with the drive home. That 10, 20, or 60-minute commute that used to be a time for decompression, for listening to music or a podcast, slowly becomes a silent, white-knuckle replay of the day. The insults from a psychotic patient, the desperate sobs of a teenager who tried to end their life, the hollow look in the eyes of a veteran reliving a war zone on an inpatient unit. These things stop being events that happened at work. They get in the car with you. They sit at your dinner table. They follow you into your dreams. This is the beginning of the crack. The loss of sanctuary. The place where you are supposed to recharge becomes just another room haunted by the ghosts of the ward. You start to feel a dull ache behind your eyes that never really goes away. You find yourself becoming irritable with the people you love most, snapping over spilled milk because your emotional reserves were completely drained dealing with a patient who threw a tray of food at your head an hour earlier. You are physically home, but your mind is still back on the unit, running through checklists, second-guessing a medication decision, worrying about the patient in seclusion. This is compassion fatigue. It's a term we hear a lot, but it's a sanitized, clinical phrase for a brutal, soul-crushing experience. It's the profound emotional and physical exhaustion that comes from treating and absorbing the trauma of others, day after day, without a chance to adequately heal yourself. Imagine a firefighter who is never allowed to leave the burning building. That is the psychic reality for too many psychiatric nurses. Let's talk about a nurse we'll call Michael, though he is really a composite of hundreds of nurses I've known and stories I've heard. When Michael started in psych nursing, he was the ideal. He had boundless energy, an almost unnerving ability to connect with the most withdrawn patients, and a belief that he could make a difference. He'd spend extra time with the catatonic woman in room 204, just sitting with her, talking softly until one day she finally spoke a single word to him. It was a monumental victory. He'd de-escalate the most agitated patients with a calm voice and genuine empathy, preventing countless violent incidents. He was the guy you wanted on your shift. He was the rock. But rocks wear down. After 5 years, the victories felt smaller, and the traumas felt bigger. He saw the system's revolving door firsthand. The teenager he'd worked so hard with, who had a successful discharge, was back 3 months later after an overdose. The veteran he'd connected with over shared stories of their grandfathers ended his life a year after leaving the hospital. Each one of these events added another layer of weight. The administration, meanwhile, was pushing for higher patient turnover, shorter stays, quicker discharges. The paperwork piled up, stealing time that he used to spend just talking with patients. Staffing ratios got worse. One nurse for 10, 12, sometimes more acute psychiatric patients. It was an impossible task. He wasn't just a nurse anymore. He was a crisis manager, a security guard, a social worker, and a pharmacist all at once. The cracking began. Michael, the master of de-escalation, started to feel a flicker of fear, not empathy, when a patient's voice was raised. He started to see the new admissions not as people with stories, but as a list of problems and a mountain of paperwork. He became cynical. He started making dark jokes with the other nurses, a common coping mechanism on these units, but his had a harder, more bitter edge. He was building a wall, brick by painful brick, to protect what little was left of himself. He didn't realize that he was walling himself in, not walling the trauma out. The critical incident came on a Tuesday. It was the end of a 12-hour shift, his 4th in a row. He was exhausted down to his bones. The unit was short-staffed again. A new patient had been admitted, a young man in the throes of a severe manic episode, fueled by substances. He was loud, intrusive, and verbally abusive. The Michael of 5 years ago would have seen the terrified young man behind the illness. He would have approached with patience and calm, but this was the new Michael, the cracked Michael. He was tired. He was numb. He saw the patient as a problem to be managed. He went through the motions of the intake, his voice clipped, his questions perfunctory. He missed the subtle cues, the clenching jaw, the darting eyes, the way the young man's leg was bouncing with a furious, contained energy. He saw the agitation, but he didn't feel the desperation behind it. He documented the behavior and moved on to his other 10 patients. An hour later, that contained energy exploded. The young man, feeling unheard and cornered, assaulted another, much more vulnerable patient. It was brutal and sudden. Staff swarmed, a code was called, and the situation was eventually controlled. But the damage was done. The other patient was injured, terrified, and psychologically set back months in their recovery. And in that moment, standing in the chaotic aftermath, Michael's wall crumbled. It wasn't the yelling from his manager, or the looming incident report, or even the fear of a lawsuit. It was the look on the injured patient's face. a look of pure terror and betrayal. And it was the sudden horrifying realization that he, Michael, the protector, the caregiver, had failed. He hadn't just missed the signs, he hadn't even been looking for them. His burnout, his cynicism, his emotional armor had made him blind. In the world of healthcare, there's a concept called the second victim. The first victim is the patient who is harmed. The second victim is the healthcare provider who was involved in the error. They are left to grapple with immense guilt, shame, and professional anxiety. They are often isolated, investigated by their own institution, and left to process the trauma alone. Michael was now a second victim. He had become a casualty of the very war he had been fighting. This isn't just one story. This is the reality playing out in psychiatric facilities across the United States. Nurses are being pushed to the brink by a system that demands infinite compassion from a finite resource. They are heroes in an impossible situation, but when they fall, the system that broke them is often the first to judge them. They are suffering from astronomical rates of PTSD, anxiety, and depression. And what is truly terrifying is that the rate of suicide among nurses is significantly higher than in the general population. The people we entrust to save the lives of our most vulnerable are losing their own at an alarming rate. So Michael stands at a crossroads, a place where so many psychiatric nurses find themselves. His confidence is shattered. His love for his job has been replaced by fear and guilt. Every patient he sees is now a reminder of his failure. He is a healer who is now deeply wounded. And the question that hangs in the air, thick and heavy with consequence, is what happens now? What does a nurse do when the job of saving others has cost them a piece of their own soul? For the nurse, what happens next is a strange and hollow dance of procedure. There is a debriefing, a formal review. The questions are sterile, clinical, focused on protocol and documentation. Did he follow the safety plan? Was the risk assessment documented correctly? Each question, while necessary for the institution, feels like a small sharp stone being thrown at his already shattered confidence. He answers in a monotone, the words tasting like ash in his mouth. He is a data point in a sentinel event report, a variable in an equation of liability and risk mitigation. The system, in its effort to protect itself and learn, inadvertently isolates the very person at the epicenter of the grief. His colleagues are kind but cautious. They offer a hand on the shoulder, a quiet "Are you okay?" in the hallway. But they are also busy. The unit doesn't stop. The other patients still need their medications, their therapy, their own crises managed. The relentless forward motion of the hospital is a brutal contrast to the stillness that has taken root inside him. He feels like a ghost haunting the halls of his own life, watching the world continue on a timeline he's no longer a part of. This is the hidden pandemic within American healthcare. The profound psychological toll on its caregivers. It has a name: secondary traumatic stress. It's not just burnout from long hours and heavy workloads. It's the emotional residue of bearing witness to another person's trauma. It's the cost of absorbing fear, despair, and pain day after day. For psychiatric nurses, this exposure is not an occasional hazard. It is the very fabric of their job. They are the frontline sponges for human suffering. And a sponge can only hold so much before it becomes saturated. Studies show that nurses, particularly those in high-stress fields like psychiatry and emergency medicine, experience rates of PTSD comparable to combat veterans. Yet there's a profound stigma. The culture of medicine often prizes stoicism and resilience above all else. To admit you are struggling, to confess that you are not okay, can feel like a professional failure. It's a dangerous paradox. The very people we entrust with our mental health are often the most hesitant to seek care for their own. They are expected to be the healers, the strong ones, the rocks in the storm. But even rocks can be worn down by a relentless tide. The nurse takes his mandated time off. The days are a blur of staring at walls and replaying every single interaction with the patient he lost. Every word, every glance, every choice is scrutinized under a microscope of guilt. He questions his career, his skills, his very identity. Who is he, if not a healer? And what kind of healer lets this happen on their watch? He is trapped in a feedback loop of self-recrimination, a solitary confinement of the mind. One evening, his phone buzzes. It's a text from a senior nurse on his unit, a woman with 20 years of experience and a reputation for no-nonsense compassion. The text is simple: coffee. Tomorrow, 10 a.m. My treat. It's not a question. It's a summons. He almost doesn't go. But a part of him, a small flickering ember of hope, pushes him out the door. They sit at a small table in a nondescript cafe. far from the hospital. She lets him sit in silence for a long time, just stirring her coffee. She doesn't ask him if he's okay. She doesn't offer empty platitudes like "it wasn't your fault" or "you did everything you could," because she knows those words are meaningless right now. Instead, she looks him in the eye and says, "My first was a college kid, a freshman. He was brilliant, funny. He was going to be an astrophysicist. He used a bedsheet." The clinical, stark detail hangs in the air between them. She continues, her voice steady, not devoid of emotion, but weathered by it. She tells him about her own dark days that followed. The sleepless nights. The fear that she would never be a good nurse again. The moment she almost walked away for good. She doesn't offer him a solution. She offers him something far more valuable. A shared experience. She opens the door to a secret, silent club that no one ever wants to join. The Club of the Wounded Healers. She shows him that his pain, as unique and agonizing as it feels, is not a solitary island. It is a territory that others have navigated before him. In her story, he doesn't find absolution, but he finds something that might be even more important. He finds connection. He is not the first, and he will not be the last. This is the informal yet vital support system that keeps so many nurses from succumbing to the weight of their work. It's the whispered conversations in the break room, the after-work phone calls, the dark humor shared over a gurney that would shock anyone outside their world. It is a culture of shared understanding born from shared trauma. They create their own life rafts because they know better than anyone that the institutional ones are often not enough. In that coffee shop, something inside the nurse begins to shift. The crushing weight of his isolation lessens, even if just by an ounce. He sees in this older nurse not a broken person, but a stronger one. Her past pain hadn't destroyed her. It had been integrated. It had deepened her empathy, sharpened her instincts. It had made her the very nurse that everyone, including him, looked up to. She wasn't a healer in spite of her wound. She was a healer because of it. He realizes he stands at a crossroads. One path leads away from nursing, away from the pain, and into a different life. It's the safe path. The other path leads right back into the fire. It's a path that accepts that this scar will now be a part of him forever. It acknowledges that he will never be the same naive, optimistic nurse he was before. That innocence is gone, but perhaps, just perhaps, it can be replaced by something more durable. Wisdom, humility, a profound first-hand understanding of the stakes. He finishes his coffee. For the first time in weeks, he meets his colleague's gaze. He doesn't have to say anything. She knows. He has made his choice. He will go back. He will walk back onto that unit, carrying this new, heavy knowledge with him. He is a healer who has been deeply wounded, but he is still a healer. The wound, however, has changed him irrevocably. It has become a part of his professional DNA. But how does a changed man, a scarred healer, return to the front lines? How do you treat the very illness that has left its mark on your own soul, without letting it consume you all over again? The answer is you do it carefully. You do it with intention. You do it one breath, one step, one patient at a time. Michael didn't return to the floor the same man who had left it. The easy confidence, the almost casual bravery was gone. In its place was something quieter, more deliberate. A hyper-awareness that hummed just beneath his skin. His colleagues saw it. They gave him space, their quiet support a testament to the unspoken understanding that binds those who work on the front lines of mental health care. They knew he was walking back into the very fire that had burned him. His first few weeks were a tightrope walk over a chasm of memory. Every loud noise, every sudden movement sent a jolt through his nervous system. He found himself charting with his back to the wall, a primal instinct he couldn't shake. He was a nurse, a caregiver, but he was also a survivor, and the two identities were now fused, inseparable. The real test came on a Tuesday afternoon. A new admission, a young man named Alex, was spiraling. He was in the throes of a psychotic episode, his eyes wide with a terror that Michael recognized with sickening familiarity. Alex was lashing out, not with malice, but with the desperate, cornered animal fear of someone whose own mind has betrayed them. Two other nurses were trying to de-escalate, their voices calm but firm, their stances ready. But Alex wasn't hearing them. He was trapped in his own private horror film. Michael watched from the doorway of the nurse's station, and for a paralyzing moment, he was back in that room, the scent of antiseptic and fear filling his lungs. His heart hammered against his ribs. The old Michael would have charged in, confident in his training, his physical presence a tool to command the situation. But the new Michael, the one forged in trauma, did something different. He didn't raise his voice. He didn't move quickly. He simply stepped into the hallway, positioning himself where Alex could see him, but in a non-threatening way. And he waited. When Alex's frantic gaze finally landed on him, Michael didn't offer platitudes. He didn't issue commands. He just met his eyes and said, his voice barely above a conversational level, "I know you're terrified." The words cut through the chaos. Alex froze. His chest was still heaving, but his eyes, for the first time, focused. Michael took another slow step. "I know what it feels like when you can't trust what you're seeing. When you feel like the walls are closing in and there's no way out." He wasn't speaking from a textbook. He wasn't reciting a de-escalation script. He was speaking from a place of shared experience, from the scar tissue on his own soul. "You are not alone in this feeling," Michael continued, his voice a steady anchor in the young man's storm. "We are not going to hurt you. We are here to help you find your way back. Just look at me. Just breathe with me." And in that moment, the entire dynamic of the room shifted. Alex, seeing not a guard or an authority figure, but a man who seemed to genuinely understand the unique terror gripping him, slowly, raggedly, began to follow Michael's breathing. The tension bled from his shoulders. The fight went out of him, replaced by a wave of bone-deep exhaustion. He eventually allowed the nurses to guide him to the quiet room, sinking onto the cot, the storm inside him finally beginning to subside. Michael had used his wound not as a weapon, but as a bridge. His trauma had become a source of profound, almost radical empathy. He could now see the landscape of his patient's fear not as a clinician observing from a safe distance, but as someone who had walked through that same valley himself. This is the alchemy of the psychiatric nurse. This is the transformation of pain into purpose. Michael's story, while dramatic, is not an anomaly. It is a concentrated version of the reality that every single psychiatric nurse in America lives with every single day. They are the ones who voluntarily walk into the epicenter of human suffering. They are the crisis managers, the listeners, the medication administrators, the de-escalation experts, and the steadfast keepers of hope when a patient has none left for themselves. They absorb the anger, the despair, the paranoia, and the sorrow of their patients, acting as a human buffer between a person in crisis and a world that doesn't understand them. This work comes at a cost. The rates of burnout, of compassion fatigue, of secondary traumatic stress among psychiatric nurses are staggering. They are asked to mend the most complex fractures of the human mind, often with inadequate resources, insufficient staffing, and in the face of a stigma that devalues both their patients and their profession. They perform this invisible, emotionally laborious work day in and day out, and then are expected to go home, to be present for their families, to simply switch off the part of their brain that has spent the last 12 hours navigating the fragile architecture of broken minds. The vital role of the psychiatric nurse in the American healthcare system is not just to manage symptoms. It is to bear witness. It is to sit with a patient in their darkest hour and through their calm, trained, and compassionate presence, communicate a simple, life-altering message. You are a human being. You have value. You are not your illness. And you are worthy of care. They are the ones who see the flicker of the person behind the psychosis. They are the ones who learn the language of a patient's delusion to build a bridge of trust back to reality. They are the ones who celebrate the smallest victories, a patient who showers for the first time in a week, one who makes eye contact, one who is able to articulate a feeling instead of acting it out. These are not small things. They are seismic shifts in a person's journey toward recovery, and the psychiatric nurse is the one who provides the stability for that ground to move. They are the unsung heroes in a field of medicine that is itself relegated to the shadows. While a cardiac surgeon can point to a scar and say, "I fixed that," the work of a psychiatric nurse is written in invisible ink on the human soul. It's the panic attack that was averted, the suicide attempt that was prevented through careful observation and conversation, the trust that was painstakingly built over weeks, allowing a patient to finally accept the help they so desperately need. So when we talk about healthcare, when we praise the doctors and surgeons who save lives, we must make room in that narrative for these guardians of the mind. We must recognize that the health of our nation is not just measured in heart rates and blood pressure, but in our collective mental well-being. And on the front lines of that battle, holding the line with courage, empathy, and an astonishing degree of resilience, is the psychiatric nurse. They are not just treating an illness. They are defending the very essence of what it means to be human, reminding us, one patient at a time, that no mind is too broken to be treated, and no soul is too lost to be found. They are the quiet, steady heartbeat in the chaotic cathedral of the mind. And their work is nothing short of vital,